So hi, I'm Hannah Zevin, and it is my absolute pleasure to welcome you all here on this Saturday. I'm the founding editor of Parapraxis magazine and the co-director with Alex Colston of the Psychosocial Foundation. And we're hosted by these two groups, Parapraxis, which is a brand new magazine of psychoanalysis on the left, which you can see here, and the Psychosocial Foundation. And they have a joint mission, which is to advance nonprofit educational work at the intersection of the social, the political, and the psychological. And we're home to multiple persuasions within psychoanalysis and leftist thought, not just the tradition inaugurated by Sigmund Freud. And our products and programming, including this amazing event, thank you so much to all our speakers and to Noor, illuminate the psychogenetic dimensions of culture and society, mental health and medicine, and political life. We are committed in all of our activities to the radical horizon of political emancipation, and we want to be and hope to be a resource for clinics and clinicians, universities and academics, writers, artists, activists, and the wider public alike. So I'll turn things over in 1 second to Noor, but just quickly to say we have only one more event this year, our first year, which will be on December 4th. We'll be celebrating Feminine Singularity by one of the contributing authors of Parapraxis, Ranjana Chatterjee, and it's stacked event. It will be great. And I hope you all come back for that. I will now turn it over to Noor Asif, who is a critic and a writer, a scholar, and one of the founding editor group members of Parapraxis, who will be talking to us both about the clinic and today's speakers. I'll turn it over to you, Noor.
Thank you, Hannah, for that introduction and for inviting me to moderate today's conversation on the clinic, the latest installment in the Psychosocial Foundation and Parapraxis magazine's ongoing conversation series. Today's conversation brings together the work of Dr. Francisco Gonzalez, Dr. Ankhi Mukherjee, and Dr. Camille Robcis, whose engagements with psychoanalysis converge around the relationship between the psychic and the social as it manifests in what we might call the clinic. Before I formally introduce our speakers today, I just wanted to share some thoughts that I had about the clinic as I was preparing for this conversation. The clinic is not to be understood as a static or monolithic institution, but rather as a site of perpetual transformation and disruption of hierarchy. The clinic, in other words, is a place that can carry the potential for revolution. Rather than envision the clinic as an enclosed space, these thinkers follow Frantz Fanon in conceptualizing the clinic as an open-door institution, such that the social and psychic converge in what emerges as an ethics of everyday life, unconstrained by walls or doors or even money. The clinic pushes beyond the practice of one-on-one analysis between an analyst and patient and invites us to consider the therapeutic potential for psychoanalysis in the context of underserved and marginalized communities. The clinic also opens us up to what Felix Guattari called transversality, a form of transference that illuminates collective expression and implies a playing of roles, so that analysts and patients, in the plural, can emerge more fluidly in unorthodox settings and through explorative practices. As these participants put forth, the clinic is a space that integrates theory with praxis. It also forces us to expand the classical and conventional psychoanalytic frame of the analyst and patient to the level of the institution and the group. Thinking through the clinic allows us to consider psychoanalysis in the context of groups affected by large-scale social, political, and economic upheavals. As all of the speakers in today's conversation seem to argue, the clinic allows us to reconfigure psychoanalysis and the relationship between the psychic and the social, forcing us to accept and reckon with the direct effects of structural violences like capitalism, racism, and colonialism on our psyches. So now I'm going to introduce our speakers. Dr. Francisco J. Gonzalez, MD, is personal and supervising analyst, community psychoanalysis supervising analyst, and faculty at the Psychoanalytic Institute of Northern California, where he also helped found and serves as co-director of the community psychoanalysis track. His teaching and writing focus on the articulation of the social within individual and collective psychic life. He serves on the editorial boards of Psychoanalytic Dialogues, Journal of the American Psychoanalytic Association, and Studies in Gender and Sexuality, as well as on the Holmes Commission on Racial Equality in American Psychoanalysis. He practices privately in San Francisco and Oakland and in the public domain at Instituto Familiar de la Raza in San Francisco, where for the last 25 years, he has worked as a psychiatrist and consultant for psychotherapists. Dr. Ankhi Mukherjee is professor of English and World Literatures at the University of Oxford and a fellow in English at Wadham College. Her most recent book, Unseen City, The Psychic Lives of the Urban Poor, published by Cambridge University Press in 2021, has just won the Robert S. Liebert Award for Applied Psychoanalysis, conferred jointly by the Columbia University Center for Psychoanalytic Training and Research and its affiliated society, the Association for Psychoanalytic Medicine. Mukherjee's second monograph, What is a Classic? Postcolonial Rewriting and Invention of the Canon, published by Stanford University Press in 2014, was awarded the British Academy Prize in English Literature. Her other publications include Aesthetic Hysteria, The Great Neurosis, in Victorian Melodrama and Contemporary Fiction, published in 2007 by Routledge, and the collections of essays she has edited, namely A Concise Companion to Psychoanalysis, Literature, and Culture with Laura Marcus, published by Wiley Blackwell in 2015, and After Lacan, published by Cambridge University Press in 2018. Mukherjee has published in competitive peer-reviewed journals, including PMLA, MLQ, Contemporary Literature, Parallax, and the Cambridge Journal of Postcolonial Literary Inquiry, and sits on the editorial boards of several international journals. She will be faculty at Harvard University's Institute of World Literature in summer 2023. At present, she has 2 books under contract and is writing a very short introduction to postcolonial literature. That's the title, in the widely circulated VSI series, published by Oxford University Press in 2023. And she is also co-editing a collaborative volume titled Decolonizing the English Literary Curriculum, published by University of Cambridge, or Cambridge University, 2023. Thank you. Dr. Camille Robcis is a professor of French and history at Columbia University. She specializes in modern European history with an emphasis on gender and sexuality, France, and intellectual, cultural, and legal history. She is the author of The Law of Kinship, Anthropology, Psychoanalysis, and the Family in France, published by Cornell in 2013, and of Disalienation, Politics, Philosophy, and Radical Psychiatry in Post-War France, published by University of Chicago in 2021. She is currently working on a new project tentatively titled The New Culture Wars, An Intellectual History of Anti-Genderism. She has received fellowships from the Penn Humanities Forum, LAPA, Princeton Law and Public Affairs, the National Endowment for the Humanities, the Institute for Advanced Study, and the John Simon Guggenheim Foundation. So welcome all of you, and I will now turn it to Francisco.
Thank you very much, Noor. And it's such a pleasure and an honor to be on this panel with such distinguished scholars. It's and Camille, I really appreciated your work. It's been personally useful to me as a form of developing clinical praxis. And I think that these kinds of spaces, these interstitial spaces, are so important for the kind of interventions that we're hoping are going to animate psychoanalysis going forward. I wanted to start with a reflection that Ankhi cites in her book, which is so brilliantly fertile, about the unseen city, by Julian Stern, the head of psychiatry at Tavistock and the Portman Trust. Stern and his colleagues pointed out that while psychoanalysis is flourishing, it has tended to the valorization of individual, intense analytic work in the private sector, rather than analysts giving back to the community. And this is certainly commensurate with my own experience, having worked for the last 25 years in a community mental health setting, which serves poor, Spanish-speaking, predominantly immigrant, and often undocumented people in the gentrifying neighborhood of the Mission in San Francisco. And having trained as a psychoanalyst, whose colleagues almost all started their mental health careers in community mental health settings, but who now characteristically practice almost exclusively in private practices. It's difficult to do psychoanalytic training in the United States and do otherwise than practice privately. The training cases required for academic advancement, typically 3, 4, or 5 times a week in an office setting on the couch, are virtually impossible to come by in any setting other than the private practice one. Psychoanalysis suffers thereby. The reification of psychoanalysis by prescription, or rather we might say by proscription, to a number of meetings per week and on what piece of furniture the analysand is to occupy, we might consider a symptom. Organized psychoanalysis, institutional psychoanalysis, also suffers from reminiscences, as Freud said, of the hysteric. It has repressed, in the political sense of the word, seminal parts of its history and its intellectual inheritance. It becomes increasingly clear that the institute itself must now become a site for clinical intervention. Organizational psychoanalysis itself must be taken as the patient, and there must be a psychoanalysis of psychoanalysis. This is where the work of Ankhi and Camille and other extra-institutional psychoanalytic thinkers becomes critically necessary to our collective project, for they re-engage and animate the transitivity at the heart of enlivening psychoanalytic work by recovering non-hegemonic histories and demanding an interdisciplinary dialogue. Though it typically acts otherwise, the Psychoanalytic Institute is not, of course, co-equivalent with psychoanalysis. Writing from the position of community psychoanalysts, Lonnie Chow and Maria St. John in a 2021 paper assert, quote, "The psychoanalytic institutes are invested in perpetuating the notion that authentic and correct ways of understanding and practicing psychoanalysis may be dispensed only through proper channels. In fact, psychoanalysis is polyvocal and polymorphous. It exists as an infinite network of practices and discourses. Some instances of psychoanalytic practice claim long lineages. Others imagine themselves to be spontaneous eruptions. Psychoanalysis is at its best when it is both disciplined and wildly creative, engaging, responding, and adapting to the communities in which it is lived and practiced," end quote. In Just Us, an American Conversation, the last volume of her poetic trilogy on the pernicious life of everyday racism, Claudia Rankine returns again and again to what she calls liminal spaces. These kinds of places are marked by transit and contingency. Like the bar stool, the barbershop chair, and the analytic couch, they are places where you can say a lot to a stranger. And it's here that Rankine finds ways to engage white business class flyers in dialogues about their white living, as she calls it. At its core, contemporary psychoanalysis is marked by this kind of liminality, by the in-betweenness of conversation with an other, marked by a now ubiquitous radical turn away from the intra-subjective, which characterized it in mid-20th century, and towards the intersubjective, anchored in the luminary figures of Winnicott, Bion, Laplanche, and Lacan, and so forth. Psychoanalysis would purport to be a site of transitivity then, if I can borrow that word from mathematics and queer its use a bit. But this incandescent concern with liminality, with the transitive, with crossing and movement and engagement across boundaries, which seemed to be where psychoanalysis had located the life-giving forces of the erogenous, is woefully missing when it comes to the institutional life of the discipline itself. The Psychoanalytic Institute, capital I, styles itself the hallowed bastion of legitimate knowledge and praxis. The history of 20th century psychoanalysis is a history of institutional fracture, fraught with schism, with much of the turmoil centered on questions of theoretical validity and purity of method, the unalloyed gold of so-called real or true psychoanalysis. Fueled by fragmentation and the discipline's inability to construct a comprehensively integrated theory, reactive insularity has pushed psychoanalysis ever towards irrelevancy if it's not able to do something that's more pluralistic. So argues Stepansky in his book, Psychoanalysis at the Margins. Bombarded by the multiple discontents of what passes for civilization, the Psychoanalytic Institute now peers out from a century of fortified tower building, a little rattled, anxious, and guilty. Current debates about educational standards, the training analyst system, curriculum, and session frequency for bona fide training cases rage in the American Psychoanalytic Association along with the International Association. At stake is the territory of psychoanalysis, who defines what it is and who authorizes those who may practice under its imprimatur. To institute really means to begin, to set out, but the typical institute of organizational psychoanalysis, perhaps especially in the United States, has too often become something of a calcified edifice instead. Psychoanalyst and philosopher Cornelius Castoriadis postulated that the institution is a for itself, like a bacterium, a cat, a human subject, or any other organism. As entities for themselves, institutions possess the agency of symbolic bodies, of collectivities with intentions that cannot be reduced to a summation of their individual members. The for itself of institutes can be likened to the ego of the individual, with its tendency to pattern recognition and assimilation, imaginary closure, and the domestication of the new. Though he's writing specifically about therapeutic institutions and their milieus, it is useful here to use Guattari's principle of transversality, which we might hear more from Camille. Guattari opposes the concept of transversality to both the hierarchical verticality of the institute, what he calls, quote, the organome of pyramidal structure, end quote, and its social horizontality, what he calls, quote, a state of affairs in which things and people fit in as best they can with the situation in which they find themselves, end quote. To think transversally is to consider the ideologies and structures underlying these hierarchies and socialities, to become more aware of the undergirding contexts which frame acceptable ways of being. Restrictions of movement, including the limits of what can be thought or said in analytic society, of how one is to comport oneself as an analyst and so forth, are effects produced in part through a disavowal of what I would call the social unconscious of the institute, understood as the inheritance of a particular psychoanalytic history, which reproduces the institute as the exclusive site of authorization of a true psychoanalysis. To make this social unconscious manifest and usable for creative growth in the collective, the relationship between individuals, dyads, various groups and subgroups, and the institute as a whole must become the subject of analysis itself. This is the analysis of the institute. The focus on transversality is a way to position, in the current sense of social positionality, both singular subjects, groups and subgroups, and their relationships to each other. Positionality implies a necessary decentering. The social position of the subject is specifically not a universal one, and thus others are required to locate that subject, to help open the blinders of unexamined history in order to see the fenced setting more clearly. Foucault makes a more fundamental point about the necessity of others when he writes, quote, The fundamental point of anchorage of the relationships, even if they are embodied and crystallized in an institution, is to be found outside of the institution. Not for the first time, we recognize the hallucinatory walls that purport to keep the illegal aliens out, for the tower walls of the Institute cannot possibly domesticate and interiorize what ultimately anchors it. That is to say, that which lies outside. I say hallucinatory because this exigency, exteriority within, or extimacy, to crib a word from Lacan, is constitutive for the Institute, yet in its most rigid iteration, at least, the Institute has tended to imagine itself a bastion of interiority and self-sufficiency. I believe institutions of psychoanalysis are important, however, as sites of learning and development, especially as regards the practice of clinical forms of psychoanalysis. What I've advocated in my work might be called a transmural psychoanalysis, one with a foot in the institute and another foot outside of it, with the aim of transforming the ivory tower walls into something more like breathing skin. Transitivity, as I am using it, is loosely linked to the notion of psychoanalysis as a polyvocal, polymorphous entity, which can assume a variety of forms and structured practices. Psychoanalyst Husserl calls these forms concretizations and names the couch and chair option as merely one among several concretizations of psychoanalysis. He includes infant observation as another. I think we can add horticultural therapy, social and milieu therapy, and community psychoanalysis more generally. I want to mention briefly, and maybe in the discussion we can talk about it more, a particular intervention at my institute, the Psychoanalytic Institute of Northern California, which has the aim of trying to institute this transmural psychoanalysis. That's been the development of a formal community psychoanalysis track, or the CPT. The CPT is affiliated with a group called the Community Psychoanalysis Consortium, a network of community mental health organizations which are committed to working psychoanalytically and who provide mutual recognition and support, cross-pollinating philosophies and strategies in providing mental health care, and help develop projects for the community track, which is a training track for candidates. The CPT offers candidates at Pink the ability to do work in the community and for that to count as a psychoanalytic case for analytic academic progression. Candidates are paired, go into a community organization where they provide a certain kind of reflecting group for clinicians of that community organization. To date, we've worked in the criminal justice system, in a refugee and asylum organization, and also with a peer wellness center. The candidates then come once a week and present process material from those groups and from work that they do with a site liaison in the community agency, present all of that as process material to a supervising group, which is composed of community psychoanalysis supervising analysts, people who've had specific training in both community and conventional psychoanalysis, and also what we call community consultants, who are psychoanalytic practitioners who are not formally trained as analysts. This provides a certain kind of positionality between those who inherit the traditions of a formal psychoanalysis and those who work psychoanalytically, but outside of the walls of the ivory tower of psychoanalysis. That group acts as a reflecting group for the candidates and the material that they present. This has had a number of effects for the Institute. In addition to having candidates who now consider community psychoanalysis as formal, legitimate psychoanalysis, it's also disrupted the usual ways of dealing with faculty within the Institute as the CPT becomes more integrated. It's also put the Institute in a relationship with a network of community organizations, and it institutes within the inside of the walls of the Institute a vibrant dialogue between those who are institutionally trained and those who are not, providing a certain kind of destabilizing and disruptive force which is conducive to this revolutionary spirit that Noor was talking about at the very beginning of the introduction. I think I'll stop there, and then we can take things up more in discussion later. Thank you.
Thank you, Francisco. Now we're going to turn to Ankhi.
Thank you so much, Francisco. That was so rich. And I really absolutely am still thinking about the idea of transmural psychoanalysis. Thank you, Hannah, for inviting us and creating this wonderful sort of network. And thank you, Noor, for responding and kind of, collating our little bios and kind of introducing us so beautifully. Well, I'll just read out from a few written comments to keep to time. And maybe I can extemporize a little more in the Q&A. As Robert Hughes and Corinne Rohr-Malone state in the introduction of After Lacan, their edited volume on the work of the Gifrig Group, a nonprofit organization for interdisciplinary sociocultural research and interventions, the relation of clinic and theory is always an uneasy one. They trace this to the fundamental insufficiency of any generalizable theory to the experience of the clinic and its irreducibly singular savoir, the knowledge that comes out of the clinic. While Gifrig, in translating the French acronym, the Interdisciplinary Group of Freudian Research and Cultural Intervention, was started in 1977 by Willy Apollon, Daniel Bergeron, and Lucy Cantin on the basis of Freudian metapsychology and with her Lacanian orientation. The work of Gifrig at the 388, a clinic they run in Quebec for the treatment of young psychotic adults, so schizophrenia and manic depressive psychosis, has made them rework the definition of transference, the work of the analyst, and the very conception of the psychotic crisis. It's an approach to psychosis, Cantin states, where its logic is rethought in the clinic from the structure of the subject's experience. The clinic in this definition comes to stand for the space where the psychotic can develop their own subjectivity and interiority, and where they, as Bergeron puts it, can re-articulate themselves into the social. One of the first surprises for the psychotic who comes to the 388, Apollon observes, is doubtless discovering for the first time someone who is prepared to listen to him. This is Apollon's pronoun, instead of being only interested in his symptoms, his behavior, and his reaction to medication. So Apollon is referring here to the commonplace that psychiatrists and psychoanalysts consider the psychotic person incapable of dreaming, or that there is no relevance of such dreaming for psychoanalytic treatment as the psychotic person's imaginary is supposedly absorbed in delusion or hallucination. For Gifrig and the 388, dreams are particularly important for psychoanalytic treatment of psychosis, as dream content reveals the analysand's history and the events that led to the presentation of symptoms, and it also helps the analyst and analysand work around the delusion. The peculiar epistemology and ontology of the dream allows the analyst and analysand to explore verisimilitude in structures of psychosis. In contrast to the delusion to whose certainty the psychotic clings for survival against the void, the dream, the Gifrig analysts claim, is a sort of neutral territory. The research in my last book, Unseen City, the Psychic Lives of the Urban Poor, did not involve psychotics, but I cite Gifrig at length here because of the way in which its clinicians challenge and change the core concepts of analytic treatment at the clinic. As Cantin observes, what Willy Apollon brought to psychoanalysis was the idea of not beginning from what was missing in the psychotic, the kind of deficit model, if you will, but rather beginning from the experience of the psychotic. And as I said before, dreams play an important role in shaping the logic of the cure in psychoses, in that dreams are seen as constructing a new world. They're seen as opening a space in the signifier to accommodate the insistent jouissance arising from prohibition or even the imposition of language. Apollon's patient Marguerite dreams repeatedly that she is in water, knocked over by a huge wave. Drowning is imminent, but she wakes up not knowing if she perished in the water or was saved. The dream is incapable of reducing this jouissance to a desire, impossible to fulfill by definition. And this, in turn, the non-reduction of the dream to an unslakable desire becomes an obstacle, Apollon says, in the real of her relationship to others. Marguerite experiences her whole body getting away from her. Clinical discovery entails the confrontation with the analyzable as well as the uninterpretable part of the symptom. Analysis of the psychotic, Apollon says, is not intended to cure the consequences of symptoms, but learn something of their source. Again, I'm straying from the subject matter of Unseen City, but what is very fascinating, but this is also to confess that I'm beginning work with free clinics that offer their services to psychotics and kind of really looking at the intersection of psychosis and racism. What is fascinating about the Gifrick model for me is that here the treatment of psychosis works with, not against, the spontaneous process of psychosis. The phenomenon my book Unseen City uses as a starting point is of another kind of clinic, the free clinic, the dream of free mental health care, which came from Freud's Speech Act in 1918. Elizabeth Danto was one of the first historians of psychoanalysis to note the tension between psychoanalytic theory and the clinic. While his theory aimed to be ahistorical, a de facto science, Freud's clinical practice conformed, Danto writes, to the social democratic political ideology that prevailed in post-World War I Vienna. So this is from Danto's Freud's Free Clinics. So one of the first free clinics was also an ambulatorium, the word derived from the Latin root ambulare, meaning to walk around. A notable feature of the Vienna ambulatorium was a lack of distinction of class or even illness. There's no illness hierarchy in the patients registering for its services. From the lovelorn factory worker with uncontrollable blushing to the nymphomaniac patient who masturbated with a knife in Danto's colorful observation. While the free clinic phenomenon, which was developed with Freud by Otto Fenikel, Erich Fromm, Wilhelm Reich, and others, combined psychoanalytic work with social context, it was still rooted in the clinic, a specific location where repeated encounters could take place between distressed patient and the listening analyst who would address and alleviate that distress. Noting the use of medical terminology in naming this space the clinic, Stephen Frosch observes that this is both because of the prestige and also because most of the early analysts were doctors. The consulting room became the model of psychoanalysis thought of as a treatment. Unseen City takes the clinic outside of the clinic to therapeutic gardens and communities, makeshift kiosks, hospital wards, and outpatient departments and homeless shelters. The parameters of clinical practice and methodology are radically changed as a result. The timing and frequency of the sessions, the dyadic structure, the hair-trigger responsiveness to speech and its vicissitudes, and the role of the psychoanalyst in that live encounter. In the portable and ambulatory clinic, and here the ambulation is not just a lack of distinction or hierarchy, but it's also, there are several instances I record in Unseen City where analysts have actually turned up at the analysand's home. The psychoanalyst may be redefined as a clinical, and I'm using a term used by Gifrick, Antheveno, the speaker, clinical speaker. Professionals trained by Gifrick for long-term psychoanalytic follow-up. And they're also called, there are other terms that are used, and this goes back, this connects very well to what you just said, Francisco, about the community training, not just sort of, formal analysts, but people who are trained from the community. And the other terms that I've used in Unseen City are lay counselors, barefoot researchers, community mobilizers, or community champions. And I've traced the ways in which, in singular ways, these agents work toward creating a bounded space in busy community and public settings, where a flow of uninterrupted conversation may be started and maintained, and where the reciprocity between patient and care provider can still be identified as variants of psychoanalytic practice. I'll just take 2 more minutes to kind of read out a little bit from my book. And this involves a free clinic in the dusty fringes of Bangalore or Bengaluru. And I just want to kind of like describe the clinic here and leave it at that. The Samadhana Counseling Center is run by lay counselors trained by the famous psychiatrist C.R. Chandrasekhar, and a team of psychiatrists and psychologists over 25 to 50 sessions. We primarily teach counselors how to be empathetic, Chandrasekhar says, showing me a diagram that outlines the basic tenets of counseling in thought bubbles arranged around the term listening, understanding, being non-judgmental, being responsive, keeping confidences, making a change. The counselors are volunteers, mostly white-collar professionals with 2 or 3 languages. Take Castellino Patrick, an English teacher at BGS National Public School, for instance. I deal with people between 16 and 60 years of age who are loners or are depressed. We are taught to lend a listening ear to people without passing judgments. It goes a long way in helping them vent suppressed emotions, solve problems, and feel lighter, she says. One of the counselors I interviewed, Gayatri Devi Prasad, has degrees in clinical psychology and education and volunteers once a week at the center. The counselors and psychotherapists do not follow any school of treatment as such, and methodology tends to be eclectic. It can best be described as supportive psychotherapy, a combination of psychodynamic, cognitive behavioral, and interpersonal conceptual models and techniques. With rural and poor populations, the task of the counselor often begins with removing ignorance and addressing misconceptions, superstitions, unscientific beliefs around mental illness, such as bad alignments of planets, defects in the horoscope, the envious attitude of others, spirit possession, etc. Chandrasekhar recounts how on a visit to a dargah, so this is the other form of ambulation where the analyst goes to the patient, on a visit to a dargah, a shrine usually built over the grave of a Sufi saint, where mentally ill patients were chained to the wall and in the throes of spirit exorcism, he goes up to the priest and says, "This is schizophrenia, boss, send this man to a public sector mental hospital." Patients at the Samadhana Counseling Center start with an initial psychiatric evaluation carried out by Chandrasekhar. The pathological case is instantly dispatched to the nearest government hospital, which has trained psychiatrists. And the counselors decide over the course of sessions whether the patient requires medicine, therapy, or both. They devise pragmatic, workable, and time-driven sets of strategies. Through rapport building, Gayatri Devi says, we allow the patients to find their own resources. Unlike psychoanalysis, the course of treatment is short, sometimes lasting for just 2 or 3 sessions, and outcome-oriented, and the goal is the alleviation of symptoms, not necessarily designed to helping the patients know themselves or their desire. The center is designed to look not so much like an analyst's chamber or a set of doctors' chambers, but a place of active commerce where messages are received, decoded, and recoded. The hallway is divided into makeshift rooms made by temporary partitions. Patient X in cubicle 1 can easily hear patient Y in cubicle 2. It's not uncommon for sessions to be interrupted by Chandrasekhar or a member of the volunteer group wanting to consult senior therapists. The Samadhana is programmed to receive people not likely to do one-to-one therapy. The questionnaire handed out at the portals of the counseling center is filled in by friends and family, and counselors say that they draw heavily on family background as well as relying on leads and feedback from family members. The most common forms of mental disease Samadhana counselors treat are depression, anxiety, learning difficulties, neuroses related to family issues, and alcohol addiction. The duration of each session is 30 minutes. Counselors try to understand the nature of the problem. Is it guilt? Is it loss? Is it anxiety? While also addressing immediate physical manifestations such as sleep deprivation, loss of appetite, and low self-esteem. We don't go to childhood experiences because there is no time, Gayatri Devi says, matter-of-factly. Thank you.
Thank you, Ankhi. We're now going to turn to Camille.
Thank you so much. So thank you, Hannah, for the invitation. And I'm really thrilled to be here and to have this opportunity to think about this really fascinating question of the clinic with Francisco, Ankhi, Noor, and the audience, of course. I'm going to share my screen. I'm hoping this will work because I had some slides. Hang on. Share. Is this working?
Yes.
Yeah? Okay, wonderful. Okay. So what I wanted to talk about was this movement that I wrote about in my last book called Institutional Psychotherapy, because it was a movement that thought extensively about the question of the clinic and the way in which institutions, so including the clinic, could function as structures of oppression, but also as structures of psychic and social healing. So they kind of gave us, I think, some interesting methods to transform, to keep institutions and transform them into these spaces. So first, just a little bit of context about some of the historical context in which institutional psychotherapy emerged, because I think the context really helps us understand the ideas that were put forth by these thinkers. Okay, it's working, right? You can see, yes. So this is Saint-Alban, where institutional psychotherapy was born. It was born during the Second World War in this small village in central France. The context of the war was really important to the emergence of institutional psychotherapy, and more specifically the experience of fascism, because it was crucial for bringing together the cast of characters who first practiced institutional psychotherapy and laid its theoretical foundation. So as many of you probably know, the Third Reich openly embraced eugenics and the forced euthanasia of the cognitively disabled. This was known as Action T4, which resulted in around 300,000 deaths. What is less well known, however, is what was happening in France during that time. In French psychiatric hospitals, where even if there wasn't a kind of official policy of eugenics, psychiatric hospitals were letting their patients die of hunger, cold, or lack of care. So these are some of the books that have documented this. Some historians have called this the soft extermination of around 40,000 mentally ill patients. The doctors, the nurses, and the staff that worked at Saint-Alban during the war were very much aware of this reality. And so their first goal was to basically hoard enough food to feed the patients and allow them to survive the war. But along the way, they were joined by poets, artists, philosophers, and political activists who shared this interest in madness and who helped them to radically rethink the practical and theoretical basis of psychiatric care. So fascism and the war had made clear the extent to which the political and the psychic were interconnected. Not only was the murder of the physically and mentally disabled central to the Nazi project of social regeneration, but fascism, authoritarianism, and collaboration were clearly not only political choices. They also required a particular state of mind. So one of the kind of lines of institutional psychotherapy was that alienation was always social and psychic at once, that you couldn't think these two fields as separate. So you needed Marx with Freud, not Marx or Freud, but kind of the combination together. So according to institutional psychotherapy, psychiatry needed to abandon its ideal of a kind of scientific neutrality, detachment, and objectivism. This was still very much the norm in mainstream psychiatry at the time. And instead, it needed to embrace its political nature if it wanted to avoid becoming complicit with these genocidal projects like the one we saw during the war. So I'll return to these themes later, but for now, let me just tell you a little bit about one of the most important theorists and practitioners of institutional psychotherapy, François Tosquelles. Tosquelles was a Catalan psychiatrist born in 1912, one of the early founders of the PUM. So you see here what it stands. It was a political party, a political group that advocated federalism, decentralization, worker solidarity, self-management. It was basically a kind of group, one of the many groups on the left that was very critical of Stalinism, and especially the anti-democratic, authoritarian, and bureaucratic turn that the Soviet Union had taken in the 1930s. In parallel to his political activism, Tosquelles attended medical school and chose to specialize in psychiatry. So he was one of the early readers of Freud and especially of Lacan in Barcelona, and especially him and his mentor, Mirai Lopez, read the early Lacan. This is still the kind of interwar period. So, in particular, Lacan's 1932 thesis on paranoid psychosis and its relation to the personality. One of the things that Lacan argued in this book, or in his thesis, was that psychosis needed to be understood in relation to what he called a particular personality. So it was useless to kind of try to find to try to locate psychosis on the brain, as again psychiatry was still trying to do at the time, but instead it needed to be studied in relation to the patient's childhood, to the conceptual structures of the delirium, the drives, and basically the intentions behind social behavior. So in other words, for psychoanalysis and for Lacan's vision of psychiatry, which was a vision of psychiatry very close to psychoanalysis, the social was absolutely key to understand the individual, right? You could not disentangle these two aspects. In 1936, Tosquelles fought in the Spanish Civil War, and eventually, like many other Spanish Republicans, he fled to France after Franco's final victory. And there he was placed in a concentration camp, camp of Sept-Fonds. This was extremely important, again, for his kind of clinical development also. The living conditions in the camp were dire. Several of the refugees were dying of hunger, disease, exhaustion. Others were driven to suicide. They were amassed in these kinds of overcrowded barracks surrounded by barbed wire, electrical projectors, surveillance posts, as you can see in these images. And throughout his life, Tosquelles talked about the kind of carceral or concentrationist environment of the camp, right? And one of the things that it led him to was to set up a psychiatric service. So you see him here in this picture, he's with his friends. They didn't have any medical personnel, so he basically recruited whoever was around to help him set up a series of activities, so concerts, plays, etc., in the hope that these would temper the effects of what was called camp psychosis. So I think from the camp, Tosquelles really learns two things. First, he learns that psychiatry can be practiced anywhere, right? You don't need a kind of official setting or a clinic to do it. You can do it anywhere. And the second thing is that he learns is that in order to treat the patient, you also need to treat the social environment. Right? You need to treat the camp. You need to cure the camp, the hospital, the institution at the same time as you're curing the patient. And these are really the kinds of the principles that guided institutional psychotherapy at Saint-Alban and beyond. So this is one of his interviews where he says there was only one psychiatric nurse, the rest were normal people. I think this is one of the places where I conducted very good psychiatry, in this concentration camp in the mud. So I think we could summarize the challenge of institutional psychotherapy as this kind of attempt to imagine psychiatric practice within the limited confines of the clinic, but not just a psychiatric practice, a philosophy, a social theory, also at the same time, and a medical practice that could prevent the chronic reappearance of these political and psychic concentrationisms, right? So could it rethink, rework, and remap institutions to prevent them from becoming authoritarian, hierarchical, stagnant, oppressive, in the same way, for example, that the camp or the psychiatric hospital, or even something like Stalinism, right? How do we explain the fact that Marxism had gone so stale in Stalinism? So how do we kind of set up mechanisms to prevent this from happening? So this is kind of a little abstract. So let me show you some practical examples of what this looked like on an everyday basis. To desalinate the patients, the hospital and the psychiatric profession and the community at large, you needed to begin at the level of architecture. So the first step was to actually demolish the walls of the asylum. So they gave hammers to the patients, and you see the walls that are kind of surrounding the hospital. These eventually get knocked down, in a kind of very joyous post-war moment. They also separated, they got rid of all the divisions that separated each cell. So everybody slept in one kind of big room like this. Similarly, they got rid of uniforms and medical blouses so that you could no longer tell who was a doctor, a nurse, or a patient. And again, this always had a kind of practical and a theoretical goal. The theoretical goal here was to explode fixed roles, right? So you could not get too comfortable in your position as a doctor or as a nurse. And really, you had to consider the singularity of the patient's illness. Every day was organized around a series of social activities, so theater, music, movies, journal, parties. This is one example of the events that were offered in July. You see, I forget what year this is, but there's kind of fishing, football, theater, etc. There was a series of meetings also where everybody could propose an idea, an activity. Everything was up for discussion. A lot of art also. So this is, for example, ergotherapy. So the idea is that, but also a lot of artwork that was being made in these hospitals. The goal of all of these activities was to facilitate what they called new transferential constellations, to produce new commons, and ultimately to turn the clinic into a healing collective. So institutional psychotherapy had many followers from the beginning, but I'll just mention two names here that you've probably all heard of, but François Fanon, who was a medical resident at Saint-Alban. The kinds of experiments that Tosquelles and his colleagues had set up at Saint-Alban and the results they were getting confirmed many of the philosophical hypotheses that Fanon had already put forth in his early work on race and racism. So Fanon brought institutional psychotherapy to North Africa, where he continued to work with psychotic patients and wrote some of his most important political texts, including The Wretched of the Earth. So I think that it's very interesting to kind of read Fanon's more political works now that we have all the psychiatric works and this excellent anthology by Jean Calfa and Robert Young, to read them kind of hand in hand with his political works and to see how even the texts that seem less psychiatric are so infused by these principles of institutional psychotherapy and this reflection around the common, around healing, etc. The second example is Jean Houry, who was also an intern at Saint-Alban right after the war, who opened the clinic of Laborde in 1953, and who wrote a lot about psychosis and the kind of clinic of psychosis using institutional psychotherapy. And Laborde, of course, provided also a home for the philosopher, psychoanalyst, and political activist Félix Guattari. Anti-Oedipus, which Guattari co-wrote with Deleuze in 1972, can be read, I think, as a kind of philosophical complement or supplement, if you like, to institutional psychotherapy, as a manual to combat social and psychic alienation. The term they use in their book is Oedipalization, but I think that's what they mean. It's the way in which your desire gets kind of trapped and channeled. So it's both kind of social desire, but also psychic desire. This is why Foucault referred to Anti-Oedipus as a book. In the great preface that Foucault wrote to the book, he calls Anti-Oedipus a book of ethics. He says its goal was to convince its readers to give up their attachment to authority and oppression in their practices of everyday life, and to renounce what he called the fascisms in our head. So he says, I would say that Anti-Oedipus is a book of ethics, the first book of ethics to be written in France in quite a long time. Being anti-Oedipal has become a lifestyle, a way of thinking and living. How does one keep from being fascist, even especially when one believes oneself to be a revolutionary militant? How do we rid our speech and our acts, our hearts and our pleasures of fascism? How do we ferret out the fascism that is ingrained in our behavior? So I think here it's interesting, again, that even though institutional psychotherapy was born in some ways in reaction to the real fascism, right, of Hitler, of Franco, of Vichy, the idea here is also that institutional psychotherapy can give us tools to understand the libidinal nature of all politics, right? Not just of the fascism in our heads, right? And the idea here is that if the carceral environment of a psychiatric hospital or a concentration camp could be transformed into a space of psychic healing and renewed communal bond, then all institutions can function similarly when they are treated with care. So, political parties, unions, families, schools, any other institution. To produce a collective was to produce its conditions of possibility, to work through the effects of transference, countertransference, resistances, and power with constant vigilance. And I think, so it's not like you would all of a sudden, dysalienation is not something that would occur once and for all. It was a kind of always a work in progress, because again, these concentrationisms would reappear. So the goal was to dysalienate alienation again, but not once and for all. And I really like Jean Houry's a kind of summary of institutional psychotherapy, which says ne pas laisser en passer une, to never let one go, to never give up, right? To never kind of fall back on your certainties, because this is a kind of ongoing challenge and struggle. So I'll stop there. Thank you so much. Stop share.
Thank you, all of you, for sharing such incredible insights about your work. It's really generative So I have a question or two, but I would also encourage everybody to sort of make use of the chat if you have any questions. But the question that I wanted to ask is that all of you seem to put forth a commitment to psychoanalysis as an institution, as well as the clinic as an institution. But this commitment to the institution with a capital I is steeped in ambivalence. And so for Camille, I'm thinking about the commitment to theory and praxis that you express through this history of institutional psychotherapy, but also remaining wary of like concentrationism. And with Francisco, your work on this transmural approach, as well as your ideas on demarcation and framing that you didn't necessarily talk about just now, but just thinking about demarcation not as an act of closure, but of creative potential, and framing as this process of turning the static analytic frame into a more active mobile process. And with Ankhi, I'm thinking of how you do this ethnography of clinics that are derived from psychoanalysis's history of free clinics, but that stray from classical psychoanalysis. And these clinics that don't offer classical psychoanalysis to patients, but rather approaches like CBT or other forms of therapy. So I was just wondering if you could all talk about why we need such institutions now. What is necessary about these institutions, and how might we proceed through this ambivalent attachment that we have to institutions? What is gained and what is lost when we transform such institutions as the clinic?
I'm glad to jump in and start with at least some thoughts. I think that we need institutions maybe in the same way that we need egos as necessary fictions that are, help organize certain things, but that are constantly vulnerable to this kind of entrapment. Egos love to just replicate themselves and are a little anathema to what's truly new. Including, unconscious impulse and so forth. And so I think institutions have that tendency, but it's also difficult without having some sort of, egoic structure to move something forward. And so I really love, where you ended, Camille, with Uri's call and where you started us, Noor, about this kind of perpetual disruption, that it's endless. Just in that way, analysis is interminable, that one would have to continually try to disrupt that kind of domestication that's going to happen over and over again. I'll just say one other quick thing, and that's it. I think that this history of institutional therapy, which is so beautifully laid out in your book, Camille, I think that it's just that it's such a, both of your books, I think it's such a valuable text for me as a clinician, that they recover things that have been so dissociated from like mainstream analytic history to its real detriment. But how can we apply institutional, psychoanalysis to the Psychoanalytic Institute, which is much in need, of that kind of opening, so that it doesn't just keep, reproducing a kind of, say, fascistic way of thinking.
Shall I jump in? As I said, but the starting point of my book was the free clinic. It started with this Freud's promise of a psychoanalytic attention and psychoanalytic time to the poor person. And one of the things that even Freud in his lifetime, being an extremely sort of, materialist thinker, he was almost immediately think, I mean, of course, in Vienna, the indigents were school teachers, then we are not looking at similar levels of poverty or, people at the intersection of race, class, migration in the way we are thinking of poverty in the 21st century in a global frame. But, when Freud is thinking about, who he thinks are the indigents, he's always already altering the kind of orthodoxies of psychoanalysis by saying that you can train people from the community, you can have this voucher system, you can, in fact, the psychoanalytic training or the free clinic should also become a clinic for women's health and for ideas of, child psychoanalysis. So, I mean, it is always already kind of, in a way, doing things that are not strictly psychoanalysis. And I do think that the reason I mentioned the Gifrick project is that it goes a step further, and there's a very strong alignment with that, between that and the kind of work I have traced, in that it gives the mental illness. I mean, I have almost all of today worked with my collaborators at the Tavistock and Portman NHS Trust, and I worked on a horticultural therapy project with them. And these are trained psychoanalysts, right? But when they go to the horticultural therapy project, which is comprised of Turkish migrants who are illiterate in their own language. They also don't have English, and some of them have for 8 or 9 years presented symptoms that the general practitioners have not been, they're called, medically unexplained symptoms, MUS cases. And whereas these people, in the horticultural therapy project, where they, sow seeds and they tend the soil and they kind of, grow flowers, and then they cook their produce in the community shed, they start becoming less dependent on medication. They start communicating better with family. So what I'm trying to say is that even these psychoanalysts, like the Gifrick, psychoanalysts with psychotics, they think of mental illness as having an autonomous and processual quality, which they work with, not against. Mm-hmm. They try to work with that. They try to work with the aphonia. These are who don't have very much language. They have transactional language. So they work with fingers. They work through food. They work with, familial anecdotes. They work through mindfulness exercises or breathing exercises, so on and so forth. So what I'm saying is that I do think that there are kind of, in a way, dyads that are established, except this is group therapy, and the psychoanalyst themselves is not one person. It's usually a group of people who are working. So there is a dyadic conversation that's happening, but it's not happening between individuals. At the same time, that collectivity is seen as a fairly non-identical group, because that's why you have all these different case studies. It's not a one size fits all. There's somebody who's presenting a certain kind of symptoms and who has to kind of, have more talk therapy. There's another one who needs the intervention of an imam because she thinks that, the soil may have pig manure. So, there are different approaches that are, but there is still that kind of a kind of bounded space in the unbounded space of the garden. There are still time limits, and there is still that kind of a transference and countertransference that's activated by trained psychoanalysts. Thanks.
Yes, very briefly, because I think Francisco and Ankhi answered this beautifully, but I think the question of institutions was obviously central to institutional psychotherapy, and I think this is one of the ways in which it really differs or diverges from anti-psychiatry, from a lot of anti-psychiatry, especially of its period. So, and we can think of British anti-psychiatry at the time, or American anti-psychiatry, even Italian, Basaglia, and where the idea was to close down institutions, and Uri and Tosquelles were very critical of that project, because they thought that, again, institutions were necessary, I think, as Francisco said, in the same way that egos are necessary. And especially when you work with psychotic patients, I think and you're constantly exposed to the kind of dispersal of the drives, you need something to kind of tie them back in. And this is, I think, what I appreciated Ankhi's story of Marguerite, right? Because this is something they describe all the time, kind of the burst body, right? The corps éclaté. So one of the things, the institutions are necessary psychically and socially, That was something that they were very clear on. But again, the problem is that all institutions have this potential to become authoritarian. So the question is then, how do we kind of build in mechanisms to prevent them from becoming authoritarian? And so, and I think for them, institutions were necessary also because, again, they were working on psychosis, and institutions could help you. And the only tools, basically the main tool of psychoanalysis is still working with transference, right? And one of the great accomplishments of institutional psychotherapy was that they argued that transference could actually work with psychotic patients. It's just not necessarily intersubjective one-on-one transference, but what they called kind of burst transference or group transference or something like that, which again, I don't quite fully understand. Maybe Francisco can explain this to me because I'm not a clinician, but the idea is that you could have transfer with an object, with a group, or whatever else, whatever other. And so for that, again, institutions were the best way to kind of channel and offer these to kind of lay out this new form of transference, and also then capitalize it, use it clinically and socially. So again, and I think it goes back to what Ankhi was saying, right, with the garden or whatever. So it's like using these activities to precisely not cure them, because again, what does curing psychosis mean? But at least make the patients live a life that's less assisted, where they're less numbed out or completely incapable of doing anything.
Could I add something to that? That institutions may also be necessary because they become a site for institutionalized transferences. That transferences are not only, of course, individual transferences, but that in order to be able to work the social, it's very difficult to do that outside of some sort of collectivity or group. And institutions actually become a strange attractor, for all sorts of transferences that then are amenable to a certain kind of work. And certainly in this notion, Ankhi, of working with psychotics, I've been, say, at Instituto Familiar, the clinic where I work, I've been with curandera, shamanic healer, and we've gone to the house of someone that I was, as a psychiatrist, prescribing an antipsychotic to, and that very much in the way that you're speaking of, we went and we did a ritual where we sacralized the Western medication on her altar because she was, spirit possessed. And so rather than working against, as you're saying, the formations there, what we did is we worked with, and we entered this space, the therapist, this curandera and myself went to the person's house, had this whole ritual. I asperged water, and we sacralized the medication. And that's the thing that could find out this marriage. But that would require a kind of institutional analysis of Western psychiatry and indigenous practice, and being able to think about the histories and how those might be put together, like bricoleured, in some kind of way that would be workable for this patient. So institutions allow that kind of, creative fashioning too, I think, at their best.
Yeah.
That's fascinating.
Yeah, it was quite extraordinary. There's also something in what we're talking about, I think, that is very much connected to materiality and a certain strain of psychoanalysis. And again, I think that this is much more true in the United States. It'd be interesting to hear your reflections, about what happened to psychoanalysis in the United States as opposed to, say, in Europe, in Latin America, even, where the question of the social was always, I feel, much more integral to the psychoanalytic project. But in the United States, it became much more reified, I think, and much more intra-psychic. And that part of what that did was that it really excluded something about material questions. So it's not surprising that institutional psychoanalysis is born out of, a political moment when you can't turn your head away from, these realities. Or in Jess's comment in the chat, about the workings of capital in clinics and so forth, how little reflective space is allowed. That there's something, I think, about what we're all talking about that really tries to re-engage materiality, in a fundamental way, tries to bring that back into, the psychoanalytic project in a way that's not just like, intrapsychic fantasy or something like that.
Yeah, and I think that's why, for example, for Tiscayus and the early practitioners of institutional psychotherapy, Lacan's work was so important because, you know, it was almost like a manifesto within the field of psychiatry, saying that not just that psychoanalysis could kind of help psychiatry, but literally that psychiatry needed to be anchored in a psychoanalytic understanding of the subject.
Mhm.
And you know, for Lacan, this kind of the question of the individual, separating the notion of the individual and the social was simply absurd, because if you know, for Freud, all individuals are in some ways the constructed in relation to conscious and unconscious fantasies of others, or relations to others. So the other is so central to the constitution of the self that there's, I think Freudian psychoanalysis really undercuts that division between the individual and the social, because you know, they're always complementary. So the early work of Lacan, I think, was really important for the field of psychiatry, but also for the field of psychoanalysis, and saying psychoanalysis can actually help psychotic patients too, which, you know, Freud was more unsure about whether if the psychotics had such a different understanding of the symbolic and different understanding of language, then how would the talking cure help them? This was kind of, again, the why institutional psychotherapy was innovative, because they said actually it can, you know, they prescribed medication, so it's not like they were anti-medication, but they also used psychoanalytic techniques, and I think similar to what you're talking about, or you've both been talking about, this kind of idea of working with.
I think one of the things, sorry, Francisco,
No,
one of the things you said about
you
institutional
please.
structures,
Mhm.
and we are talking about the clinic, and it always makes
Mhm.
me, it reminds me of Joanna Ryan's work with Bourdieu, and she's a psychoanalyst, you know, where she says that in a way, psychoanalysis itself is a sort of space where she's citing Bourdieu here, where, you know, you insensibly internalize stereotypes, you know, about class and race. And I'm not sure that even with kind of a very socialist framework, you know, our NHS, a National Health Service, you know, it's a very sort of, you know, socialist minded framework, you know, which offers sort of Tavistock, the institution I mentioned, you know, it offers a free psychoanalysis. But what is happening is, like, there is increasingly that sort of emphasis on sort of very end-oriented evidence-based medicine. And, you know, the horticultural therapy, I worked with them until 2020. In 2022, the time that the patients had has shrunk from 1 year to 20 weeks.
Mhm.
So that's how rapid, you know, this sort of, there is no psychoanalysis to come, there will be no psychoanalysis, you know, it'll
Mhm.
really be nothing but CBT, which is also seen almost in an almost cynical way of sort of reinstating the person, you know, who has this form of you know, this form of kind of a disability, mental disability, reinstating them to the workforce. That's the sort of impetus. It's not about cultivating interiority. It's not about, you know, sort of paying attention to this person's dreams or aspirational structures, and about kind of, you know, instating capacity and capability, but it's about reinstating them into the workforce so they're not dependent on the state. So it is kind of, you know, very, it is scary to me what the clinic is doing. You know, the clinic is sort of, you know, it is kind of very much something that is reinforcing the very structures that are keeping the poor, you know.
Mm-hmm. Absolutely. And while there is, you know, in so much of, say, Freudian psychoanalysis and its aftermath, like theoretically, it's so pregnant with the social, as I think we're all saying, that its actual form of praxis, you know, which is, I think when we speak about the clinic, we're really speaking about forms of praxis in some way. That part of what it's reified a particular way of practicing, you know, by and large, into the individual dyad. And I think that and largely privatized, or you can get into the, you know, these public health, you know, kind of systems where you still have largely this kind of dyadic form of practice, which is, you know, incredibly useful. But I think that it's limiting, you know, and I think that we like to think that psychoanalysis, any kind of clinical psychoanalysis, is always applied psychoanalysis, that there's no such thing outside of an applied. There's just a lot of different kinds of ways to apply it. And so when we reify it to just dyadic practice, I think we miss so much of, like, say, horticultural therapy is necessarily a collective practice, right? And so that when you have like training centers and institutes which only like narrowly define what actual analytic practice is, then you're missing like this whole creative world, this pluripotentiality, of stuff that could happen that doesn't get really institutionalized in the best sense of the word,
Thank you for those answers. It's really interesting to hear about all of your different practices or understandings of this question. I had another question, and it's kind of different from what we've been talking about in some ways, but it's a question of method. Each of you use different kinds of methodologies in your work. Francisco, you present clinical material in a poetic register alongside what we might call auto-analysis, so sort of writing yourself into the text. And Ankhi, you draw on ethnography, literary criticism, quantitative data analysis, economics, among other methods and disciplines in your work. And Camille, you draw on, I think you cite Dominique Lecapra's idea of dialogic history to perform what you call a dialogical conversation between text and context in the archive. And so I was wondering if you could all speak a little bit more to this question of method, and if there's something about working on the clinic in particular that demands this sort of experimentation with method.
So I can jump in. One of the things that one of the terms I use, I cite Leela Gandhi on postcolonial method, where she calls it jugaad, this Hindi word, which means it's a hack, but it's not a lazy shortcut. It means making do with what little you have. But I do think, I do think that even with an book which has which is sort of in a way border crossing with impunity with so many disciplines such as Unseen City, I do believe in almost all my work was anchored in kind of and guided by people who were clinicians, because I did not really want to go there. And there are all kinds of ethical problems with making these case studies, sort of thought experiments, so I had to be really guided by, a lot of the time these was psychiatrists who were using psychoanalytic psychotherapy. So, in the Indian examples, many of them are psychiatrists. In the examples from New York, they're psychiatrists who are using psychoanalysis. But I wanted that sort of a clinical steer or guide to understand how the jugaad, how the hack happened. So they were not happening out of nowhere. I was not going and experimenting with these methods, despite my sort of very deep and very sustained knowledge of the history and theory of psychoanalysis. So I do think that there is, I do believe in that kind of training. And I do think it's from that place of training that you can, think of that the kind of psychoanalysis to come, that Bjorn talks about, and the psychoanalysis of the future. And I did constantly ask them about, what is the technique, how does transference work, what was the time and frequency of the meetings, etc. So I kind of wanted them to also confront how this could still be identified as a version of psychoanalysis.
It's a lovely question, Noor. I thank you for it, and I think that Ankhi, what you're saying kind of spurs some of my thoughts as a psychiatrist who's psychoanalytically trained, and that I think that there is something about this training in, what is the psychoanalytic method, and that there is something about that method that's very much in my bones. And I suppose that that's something about like establishing a particular kind of setting, being in a kind of dialogic relationship, listening for emergent process and the unconscious, and with that then having a kind of restless skepticism about, is this really what it is? Am I when I say this, is that really what I mean, or might there be this other thing that I mean? And having this constant questioning. Fanon ends his book, Black and White Mask, which let me be a man who always questions, right? And I think that that's incredibly psychoanalytic. And so I think that method of relationship emergence and questioning, I think, feels at the heart of what I do. I'm just interested in relationships that might move beyond the dyadic, of like ways that we might listen to collective settings in that way. Thinking about, what happens institutionally if we apply that kind of method, in all sorts of different configurations that are not just dyadic, and it's including, say, in my own writing, like what am I really saying, and what am I saying that I don't even know that I'm saying, and who can say that, who can let me know what it is that I'm saying when I'm in dialogue with them, so that kind of, I think, it's a weird epistemology that we have, trying to know things based specifically on the things that you cannot possibly know.
Yeah, so Noor, you were mentioning Dominic LaCapra, who is my doctoral advisor. So it's someone whose work I love very much. But he has this notion of a dialogic relationship with text, between text and context, where basically historians sometimes treat texts as if they're just kind of symptoms of a particular context, right? There's something to illustrate a context. And for LaCapra, a text often pushes back against the kind of symptomatic reading, right? So if you kind of read texts for, with all of the kind of complexity, all their complexity, et cetera, you can see how it's not just how the text can pose questions to the context, and the context can pose questions to the text. So you don't just kind of read them flatly, but you read them in conversation with one another. And LaCapra, it's interesting again to talk about this in this context, because he's very interested in psychoanalysis, and he comes to this notion partly through psychoanalysis, the idea that authors always have a transferential relationship to their work and to their text, which is again something that makes a lot of social scientists quite nervous, because the idea that you are implying you're like projecting, you have literally a transferential relationship with the text itself, with the object of study, and he urges us to pay attention to that. But there is also a kind of transferential relationship between past and present, right? So you're writing about something that happened in the past, but how does that pose, again, questions to the present, and how does the present pose questions to that past? So I think in my case, that's how I always work. I try to kind of think about context and text together. So I read the text philosophically as deeply as I can, similarly, I think, to a literary critic or a philosopher or something like that. But always try to see how a context can change that reading, right, or influence that reading. So that's why, for example, in the Tosquelles case, I spent a lot of time talking about his life, because I think, again, his ideas only came to be, especially around this question of concentrationism, et cetera, in light of this concentration camp, in light of the war, in light of fascism, in light of his experience in the POUM. So they really shaped his activism, really shaped his psychiatric practice. So I think that was how I used content. And so all of the figures I study in the book, same thing with Fanon. The fact that he was in Algeria was obviously extremely important. It didn't have, it was kind of quite random that he ended up there. There was no reason for him. He was not Algerian, of course, and he just ends up there. But then how does that become so important for both the way in which he revises the method of institutional psychotherapy, because he realizes it's not working as well with Muslim patients that he's treating, but also for his political text, which again, so context, I think, is very interesting to think about these.
I'm very glad you mentioned that, Camille, because that's the other thing that in my work as well, I'm constantly reminded of Fanon's sort of, in a way, very angry statement in Black and White Mask, that when a person develops varicose veins from standing on their feet for very long, if they're a colonial subject, it's blamed on the weak constitution, not the long hours. Right. And this is something he's doing in Blida all the time. He's looking at how time has become pathogenic for the Arab.
Yeah.
How time has, this necropolitical time, and he's trying to kind of really again move away from language. He knows that his Arab patients will not enjoy reading Jane Austen novels or weaving baskets.
Exactly.
Both of these activities he thinks are the Arab patient, the Arab man thinks is effeminate, and he hands them shovels. So Fanon hands them shovels. So again, this is that psychoanalysis? Yes, it is kind of in a way kind of the basis of something like horticultural therapy or ecotherapy. That kind of that movement into that transitional space of the garden. But Fanon comes to it because he is he's very aware of his time and of how it is impacting the patients who he's not able to establish any transference with, while he's himself being called an Arab doctor. So there's this kind of deeply racist environment where he's being lumped with his patients, but he can't connect with his patients, and he thinks of the garden as a space. So thanks for
beautiful.
It is really beautiful, and that we can think about how that texts, say like analytic texts, like say Freudian texts, now in our context, become something that can be that can open up. That you read something like Civilization and its Discontents, and it's so pregnant with a kind of a third revision. If there was like the topographical and the structural, Freud is right there on the cusp, I think, of this revision that really would include the collective. And I think he gets to a point where he starts to think, it's not possible to explain what's happening, psychically, if I just stay with the individual. You have to have the group, right?
Yeah.
But it doesn't quite get formalized in a way. But I think that is so. This idea of an analysis that doesn't just look back and kind of like anchors everything, say, into an Oedipal childhood, but instead is looking towards a future, about how does a new future get constructed. Has everything to do with this relationship of text and context that allows new openings to occur, right? And so it's a very beautiful idea. I don't know Le Capra, but I'll
look him up. He's wonderful.
Yeah.
And it's really about kind of how to use these psychoanalytic concepts in historical writing. We're kind of limited, of course, but I think it's great.
It is.
Well, thank you all so much. We're running out of time, so I'd like to hand it back to Hannah. But before I do, I just want to say that I've really enjoyed moderating this conversation and learning from all of you.
Noor.
So thank you
very
for
much.
being
Thanks
here.
so much.
I'll just echo my extreme gratitude to our speakers, to Noor, to the audience. Again, we're now live at Parapraxis magazine. Our first issue is available for pre-order. All of the people who spoke here today have been integral and supportive and are our guiding lights. Come back again on December 4th, if it appeals to you, if you're free, and we'll hope to see you, if not, in the new year. Thank you so, so much. It's an honor.
Thank you, everyone. Thank you, Hannah.
Bye-bye.
Such a pleasure.
Hannah.
Thank you, Noor.
Bye-bye.
Bye.